Thanks for not kicking me out of Southern Medical Association and allowing me to come back today. I greet you again from the northernmost border of the Southern Medical Association in West Virginia and Morgantown, which is only about 5 miles from Pennsylvania, interestingly enough. And if I moved 5 miles north, I wouldn't be able to be in the Southern Medical Association. No, that's not true. We're going to be talking today about prevention. And so hopefully that's something that cuts across the different specialties. We're all concerned about that, and everyone can contribute to that. Actually, almost no matter what the specialty, you can offer flu shots in your office, etc. And there's also, apparently, with all my talks, there's always a lot of complications. And sure enough, prevention has been in the news so much in the last week that I had to change my slides. And if you know, it used to be simple. When you were in medical school, learning about prevention was like a 1-hour lecture out of, 4 years. And the person didn't have to change it, from 1 year to the next. And now there's a plethora of guidelines, the new hypertension guidelines, the new cholesterol guidelines, the new flu shots coming out. The new pneumonia vaccine guidelines are so bewildering that I have to carry around a chart and just keep it on the refrigerator in my office. And I give those every day. To try to remember if you're supposed to give the pneumo 13 and then the pneumo 23, or you're supposed to give the pneumo 23 and then the pneumo 13, or neither. So we're going to talk about some of those things. We're going to try to talk about the principles of adult health maintenance. And so you'll at least have some principles to go by, because the guidelines themselves are going to change. So if I give you this update, if you had got an update in December, it would be out of date. And so I didn't want to give you a talk that wouldn't have any more staying power than that. So we're going to understand the principles behind the clinical preventive guidelines and try to calm down some of the controversy, describe the resources that you need to go to and the websites you need to go to, and how to adapt a reasonable set of guidelines. I didn't say perfect set, but a reasonable set for the most common situations that you find yourself in. Now here's problem number one. There's so many different guidelines. You say, well, the guidelines from whom or from which organization? The big one, the gorilla in the room, is the USPSTF, and you have to actually practice saying that. The U.S. Preventive Services Task Force. These are the national guideline people, the experts from all over the United States that use evidence-based guidelines. They used to put out, if you were practicing in the 90s, which I think many of you were, they came out with their first book. It was a book. And they updated it again 5 years later, and then you got a new book in 2000. Well, soon after 2000, they said, we're going to put this online. And then they started updating it every day. Okay, it wasn't every day. But nevertheless, if you check on it, it's different from the last time you looked. So they can update it any time, and they don't necessarily send you an email. Now, there's other specialty organizations. So I'm in the American Academy of Family Physicians. You could be in the American College of Obstetrics and Gynecologists, American College of Physicians, etc. They have guidelines. Now, fortunately for me as a family physician, the AAFP has sort of adopted the USPSTF guidelines as their guidelines. So I feel fortunate that I'm not confused on that. But then there's the special interest societies. This week in the news, the American Cancer Society changed their guidelines on breast cancer. The American Heart Association has guidelines. The American Diabetes Association and the American Leukemia Association, etc., etc., etc. Every disease has a society, and they have their own guidelines. And then, not to mention, and we probably are not going to get into because that's a different talk, the CDC and Homeland Security and Ebola guidelines and this sort of thing. All right. So you can go to USPSTF and just Google that, or you can go to AAFP.org and they use their recommendations. That's where you can go on the web to get those. And they're just in alphabetical order by condition or problem. Now, the next thing is they actually try to minimize the guidelines. And you say, well, that's terrible. They're not giving us enough guidance. But think about the opposite situation. If they give you too much guidance, then you can be sued for not following the guidance. And so if they're very, very, very specific and they have a lot of guidelines and you're not 100% on them, which most of us are not, then you're going to be in trouble. So you actually should think of it as a blessing that they are not so directive in many of their guidelines. And second of all, we have to remember the word that guidelines is meant. They're guiding you. They didn't say you have to do it. They didn't say you can't take into account that particular patient's preferences, that particular patient's situation. These are guidelines for the average situation. If your patient or you are not in the average situation, then the guidelines don't apply, and that's perfectly understood. But you have to understand that too, that when you're not following the guidelines, it doesn't mean you're being ignorant of them. It means that the particular situation didn't call for it. So the patient and the physician should share in the decision making. The JAMA-Merenstein case, so this was in JAMA, and it was a particular legal case, and I always try to shock you during part of my talks. And so this one was a wonderful doctor, Dr. Joel Merenstein, who followed the guidelines perfectly and still got sued, and he lost. And you say, wait a minute, that's terrible. Because the guidelines said you didn't have to screen for X, Y, Z. But they said, no, screening is available, and you should have screened me. And if you'd screened me, my husband would have been alive, et cetera, et cetera. And the jury said, yeah, that's right. If screening's available, you should use it. So now I've made you all not sleep again tonight, and I apologize for it. All right, so be selective in ordering the tests. You shouldn't just order every test. I still say that we can use our discretion there. Use every opportunity to deliver preventive services. That's why you get flu shots at the grocery store, flu shots at the drugstore, flu shots at the school, flu shots at the mall, flu shots at, yes, doctor's offices. You need to use every opportunity. Second of all, we found out that people didn't have prevention immunizations or prevention done. They didn't have their cholesterol checked, and they'd been to the doctor 9 times that year. But they'd been there because of their sprained ankle or because of diabetes. And it's like, well, they didn't come for a checkup and a health maintenance exam, so I didn't do their health maintenance. Okay, that will no longer fly. If you saw them and they needed a flu shot, you should have given them one. If they needed and updated their tetanus shot, then you should have taken that opportunity to update them on their tetanus shot. And so there's a new standard now. People can't go to the doctor 9 times and not have any of their health maintenance done. That kind of record is not going to fly, anymore in today's world. Now, we have to teach people, be specific, suggest small changes. There's a lot of counseling strategies in the guidelines. And so we have to utilize, I like the way they said, this is their words, not mine. I wish I'd come up with this. To utilize the power of the profession without coercion. So you can tell them what to do gently. All right, and you want to get explicit feedback. Well, gee, why couldn't you exercise? Or what's stopping you from quitting smoking? You want to find out what their barriers are. And you want to have a system of prevention in your office. All right, and finally, you're probably familiar with the A, B, C, D, I ratings. The A ratings, there's a lot of evidence. B, there's not quite as much. C, there's not enough, but we want to recommend it anyway. D, there's not evidence. In fact, there's evidence against doing whatever it is. And I means we just don't know what to do. We're throwing up our hands. There's insufficient evidence to make a decision, okay? So now you know Now the first thing, we're going to have to go back to medical school, or some of you with MPHs. It'll be embarrassing for me to even tell you this because you know more about it than I do. And that is, what is primary prevention as opposed to secondary prevention? Primary prevention is stopping something before it starts. So for no reason. For no specific reason and no specific population. So in other words, like using your seatbelt. That's primary prevention. Everyone telling you to use your seatbelt. We don't know if anything's going to happen to you today. We don't know that you're going to have an accident, but just in case, you're wearing your seatbelt. That's primary prevention, doing it before any indication of disease or problem is present. All right? So that's immunizations, getting your blood pressure screened at the health fair. You just walked in, you just happened to be at the mall that day going to Penny's or Sears, and then they said, oh, let me check your blood pressure. I mean, there was no reason except that you just happened to be there that day. So then there's secondary prevention. Okay, it's already getting difficult because we already misused this term, but secondary prevention is you do have an inkling of the disease or problem, and the idea is early detection of asymptomatic disease. So you have it, but you don't know you have it, and we're trying to find it. That's secondary prevention, all right? To identify and treat asymptomatic persons who have risk factors or preclinical disease, but in whom the condition is not clinically apparent. So you don't have symptoms of whatever it is, but we're trying to find it, early detection, okay, and that's secondary prevention. So, treating high blood pressure. So in other words, once we find you have it, you have an early indication of pre-disease. High blood pressure, you walk around, you feel fine, you don't know you have it. We detect that so that if you have it, we're actually trying to prevent the consequences of high blood pressure, which is, of course, stroke or an MI. Mammograms to look for early asymptomatic cancer. So mammograms are secondary prevention. We're trying to, so there's some disease there already, and we're trying to detect it early before you would have noticed it. A urine microalbumin for diabetes. Common use, now this is one where I think reasonable men and women could differ, and that is, if you've had an MI, then they say, well, we're giving you a beta blocker and ACE inhibitor for secondary prevention. Well, it's sort of like, well, you had your first MI, so we're trying to prevent your second one, and they're using that word second for secondary prevention, but you already have the disease. You already have coronary artery disease. And so it's not technically secondary prevention, but don't get any arguments with epidemiologists about that. Just smile and just call it secondary prevention. That's my advice. And then there's tertiary prevention, so that's rehab. So you have a stroke, and then we're trying to prevent you from having consequences of that, or trying to help you walk after that, trying to improve your functionality. That's tertiary prevention, preventing the negative effects of the disease or restoring function. Okay, so stroke rehab, physical therapy, cardiac rehab. That's tertiary prevention. So I'm helping you all pass your board exam if you have to have that. All right, then there's before we can even talk about this stuff, we have to know what incidence is and prevalence. So the incidence is the number of new cases, so that's new. So the incidence is a new cases in a particular year. The prevalence is how many there are. So there's 100,000, the incidence of COPD is 100,000, but the prevalence would be 1 million, because there's 1 million people with COPD, but there's 100,000 new cases every year, just for example. All right? Now, not all tests are good screening tests, and they have to meet these requirements. So the disease needs to result in significant morbidity and mortality. Also, you have to have some treatment. So in other words, we don't want to have screening tests and keep screening people, but we can't treat it. So you have to have effective treatment in that early stage for there to be a good screening test. It has to be detectable in the asymptomatic period. The testing should be accurate, simple, and acceptable, of course. And here's the tricky one, and this is going to get me in a lot of trouble, but I'm already in so much trouble, and that is that treatment in the asymptomatic period has to give you a better outcome than in the symptomatic period. And this is where we get into trouble with prostate cancer. So we find it before you knew you had it. There's a screening test, a digital rectal exam or PSAs. We find it. It's treatable. There's treatment. We can remove your prostate in the asymptomatic period. And does that give a better outcome than waiting for you to become symptomatic? Well, no, not exactly. And also remember that these are public health people. And there's been some things in the news about the breast cancer thing, and they said, well, they're just playing the odds. Well, that's exactly what public health guidelines do. They take into account the risks and the percentages and the odds. And those percentages and the odds are there for all to see, and sometimes you be the judge. They are not, in other words, no, we could say, because we have the capability, now think about it, we could say, you know, we should do CAT scans for brain cancer every year. We could find all the brain cancer by doing CAT scans for brain cancer every year, but no one has suggested that. They said, well, that would be too expensive, that would be ridiculous, well, it's just not that common, was it? Well, I know, but there is a point-something percent of people that would be found by doing that. You see what I mean? We do make those judgments each day, and that's what these guideline people are doing, and they're just humans like you and me trying to do the best they can with that data. But reasonable people could differ about how to carry forth with that data, okay? I'm making a lot of excuses here. All right. It's better if the disease has high prevalence, a large percentage of undiagnosed, and the disease should have serious consequences. All right. So tests, I'm helping you pass your boards here, should be sensitive and specific, simple and cheap, safe and acceptable. Now then we have to know what sensitive, that's right. These are the principles. You have to know what sensitivity and specificity are. So a sensitive test picks up all the people that have it. So I would say, all right, I want to find all the blonde women. I know. I'm going to have a test, and it just finds if you're a woman. Well, then I'd find all the blonde women. but that wouldn't be very specific. I would have a very sensitive test, a gender test, but it wouldn't be very specific. A specific test would be, no, I'm going to check the hair. And then it's, oh, well, that's a little tougher. The specific tests are the tricky ones. Now, so those of you that are math-oriented, this is the way you do it. You make the little box with the pluses and the minuses, the true positives, the false negatives, and the true negative. And this is your formula. And if you're ever going to take a test, or you just have to sort of memorize this thing. So this is there just for your reference. The true positives over the true positives plus the false negatives is the sensitivity, whereas the specificity finds the true negatives, because if it finds them better, it's more specific. All right. Hopefully that's not all mud to you. Now, worse yet, there's this phrase called positive predictive value and negative predictive value. Now, positive predictive value and negative predictive value takes into account the prevalence of the disease. So you could have a terrific test, but if it's such a rare disease, you actually could end up with more false positives, and it wouldn't be a good test, even though the test itself is very good. If the incidence of the disease is so small, it can still have a poor predictive value. So, now I knew you were going to ask me this, so I gave you the formula for positive predictive value and negative predictive value. And unbelievably, and you'll have to just put these side by side to know that these are different formulas than I just gave you. But this is the true positives over the true positive plus the false positive. The other one was true positives over true positive plus the false negatives. So these are actually different formulas. You have to make the little boxes the same way every time, or you'll really get yourself messed up. All right? So that's for the math people. And the characteristics of a test is that it's sensitive and specific. The characteristics of the population determine the predictive value. All right. Now, I know what you want to know. You want to see some examples. So we'll try to apply this to practice. Let's talk about cervical cancer. This is what I would call a public health victory. There's 12,900 new cases. That was a couple years ago, because they're always a couple years behind in statistics, with 4,100 deaths per year. 5-year survival for localized disease is 90%, but for advanced disease is 14%. So first of all, this has the characteristics that would make it susceptible to screening. It's something that we want to find and find early, because survival is much better if we find it early, localized disease, as opposed to advanced disease. And sure enough, Pap smears have found earlier disease, and there has been a significant drop in invasive cervical cancer over the last 40 years due to screening, and reduced mortality and death. The FDA approved the cervical cancer vaccine, and that was, it seems like yesterday, and that was June 2006. The HPV, the Gardasil vaccine came out, the HPV vaccine, and for girls and women, and of course it's in males now as well. So that will reduce it even more. This is an excellent example of using the principles and having a screening test that's simple, it's safe, it's cheap, it's not painful, and it can be done quickly, and it will reduce invasive cancer. And that's why also the guidelines that were changed from every year to every 3 years, because if you're trying to make yourself have a normal cervix and just keep treating it, you do it every year. But if you're trying to detect cancer, every 3 years was enough to do that because of the growth rate of the cancer. So the Pap test, interestingly, you say, well, how can this be? The false negative is 20 to 45%, but the specificity is very, very good, okay? And the thin prep and Papnin autopap cervicography colposcopy make this a very much a better method. And the false negatives are thought mostly due to sampling error. Because cervical cancer grows slowly, you have a chance, if there's sampling error, to catch it the next time the person gets a Pap smear. So this is a graphic representation. So in other words, there's a slow onset of disease, and that you can detect it during that time between 30 and 45 or 50. The point at which the test becomes positive and the point at which the patient becomes symptomatic. There's a long period there, and that's why Pap smears work as well as they do. There's a long period of detectability before they become symptomatic. Okay, so there's routine screening of women over 21, so you don't do this in your teenagers anymore. If they're sexually active, you start every 2 years, and then if they're 30, you'd get them every 3 years if they have normal ones, and every 5 years if you do HPV testing at the same time. They can stop at age 65 if they've had 3 normal PAPs, or have had normal PAPs for the last 10 years according to the USPSTF. So you can do those every 3 to 5 years after age 30.
So from 21 to 30, is it every 3 years now?
It might be, and yeah.
So I know it's not the topic.
Yeah, no, thank you. Ovarian cancer. Okay, now this is a harder one because we don't have, although there is a time, a period where you have the disease when it's asymptomatic, the problem is detecting it. Localized disease, 5-year survival rate is 92%, whereas if it's distant metastases, 27%. So that's actually similar to cervical cancer. So you say, well, this would be a good disease to find. The problem is, and there's 21,000 cases as opposed to 12,000 cases of cervical cancer, and there's 14,000 deaths. It would be good to find this disease. The problem is we don't have a good way of finding it. The pelvic exam detects advanced cancers with poor survival. So we go and we feel it, but I mean, we feel a huge mass and we say, oh yeah, you have ovarian cancer. It's, unfortunately, the sensitivity is there, but the specificity isn't fair. I mean, you obviously could have cysts or PID or some other masses there, or scarring. So we don't do pelvic exams specifically to check for ovarian cancer. Now, we want to check because we want to know if you have it, but we don't do screening tests every year to check for ovarian cancer because it's not a very good screening test. It doesn't make a lot of sense, but it's true. And the other methods of ultrasound are the same. They're not specific, they're not sensitive, and it can't be found at an early enough stage that we can do good. We need a chemical test is what we need, and we just don't have it. So I'm apologizing for ovarian cancer. Now, cholesterol screening. Now, this is something that you probably do. You probably have heard of this. You've probably heard of cholesterol. And according to the recent guidelines, which say everyone needs a statin. No, that's not what they say. That was a joke. But the most recent cholesterol guidelines are not about treating to target anymore. They're about deciding if you need to be on a statin or not. And according to those guidelines, more than 80 million people, probably 100 million people need to be taking a statin according to those guidelines. So you have to find out if you need it, and you have to do a cholesterol test, and you have to do a lipid panel. This is because cardiovascular disease is the most common disease. Finding it early, you have a long asymptomatic period before you have a symptomatic period. Treatment is available to modify the risk and subsequently reduce the risk. So this seems like a test that you should do, you should screen, you should treat, and try to prevent that illness. And thus it is. Now, however, the only problem with that is that cholesterol levels alone are only fair predictors of coronary heart disease. You know this because there's so many other risk factors. Obesity, hypertension, family history, smoking, diet. So you know there's so many other risk factors that modify that risk. But nevertheless, cholesterol is one of those factors. But we have found that treatment reduces overall mortality in high-risk populations. And so we do screen for cholesterol. So here's the screening. Periodic screening is recommended for all men ages 35 and older. This is USPSTF. So men 35 and older. Now, this will surprise, I think this will surprise the women. Screening is not ever, I'm just the messenger, folks. Screening is not ever indicated in women. That's right, let me repeat that. Screening asymptomatic, perfectly healthy women is not indicated. You do not need to ever check their cholesterol. Check the guidelines, read them for yourself, wake yourself up with a cup of coffee and read the guidelines. Women do not have to ever have their cholesterol checked unless they have some risk factor. It just so happens that 80% of women have a risk factor. Because they have diabetes, hypertension, smoking, obesity, ethnicity, or a family history of whose parent or brother didn't have. Okay, so you see. But nevertheless, if there was a perfectly healthy marathon running 50-year-old woman running around, she never smoked, and her family was healthy, you say, no, we don't care what your cholesterol is. It's actually not a factor. It's almost unbelievable. When I tell my residents this, they run me out on a railroad. But this is exactly what the guidelines say. And so once you figure this out, you do the ASCVD, American Heart Association calculator online to determine their risk. You have an app on your phone, on your smartphone, or on your computer, and you put in their age and their gender and whether or not they smoke, and whether or not they have hypertension, and whether or not they have diabetes, and you compute the person's risk of over the next 10 years. And if it's more than 7.5%, you give the people a statin. And so that's that's online, and you just Google ASCVD calculator and you'll get it. All right, something a little less controversial. Tobacco cessation counseling is indicated. Thank you. Yes, you can tell your patients not to smoke. That's good. You can tell them to engage in a healthful diet and physical activity regularly. Thank you. And you can counsel your patients to achieve caloric balance and replace fat with fiber. So you're allowed to counsel your patients about tobacco, exercise, and obesity, and indeed, of course, you should. No matter if you're a plastic surgeon or a general surgeon or an OBGYN or a primary care doctor, you should, of course, take every opportunity for telling people, advising them to quit smoking, to exercise, to eat right, and to treat obesity. Now, here's another one that usually gets me run out of the room, aspirin. I don't want to find out your personal history, but sometimes I ask people, to raise their hand if they're taking a baby aspirin for prevention. And then what I do is I ask them if their doctor told them to, and they say, no, I just started taking it. Like, what? But it's true. Now, this is actually a little bit tricky. Men 40 to 79 years should take a baby aspirin if they have risk factors, not if they don't have any. The Physicians' Health Study, which was the giant study of Harvard graduates that upon which this was based in the original study, turned out that it was a negative study. Giving people a baby aspirin when people with no risk did not help them any. And interestingly enough, the physicians in the study, when they broke the code and they found out they were taking the placebo, they immediately started taking the baby aspirin. We are just convinced that taking a baby aspirin a day is good for you. Now, it is if you have risk factors. If you have risk factors for stroke, MI, if you have diabetes, if you have those cardiovascular risk factors, then of course you should be taking a baby aspirin. But not just in general. If you're 50, fit, healthy, your cholesterol is fine, your family history is fine, you don't need to take an aspirin. Second of all, you don't need to be taking it if you have something wrong with your stomach and if you're going to bleed to death, because the numbers are interesting. In men aged 45 to 65 at low risk, aspirin prevents 3 events for every 1,000 life years and causes 1 hemorrhagic stroke and 3 serious GI bleeds, and it prevents 14 events in intermediate risk men. So, I mean, there's your numbers. So reasonable men can differ about how they would interpret this data. But if you're 55 and you don't have risk factors, you say, well, I'm going to take a baby aspirin because I'm going to prevent my stroke, 3 events per 1,000 life years. But you're going to cause 1 stroke and 3 serious GI bleeds. And so you might want to advise those patients, like, well, no, I'll hold off on that. Okay, so think of the worst possible world. So I'm the chair of a family medicine department, and I'm treating the chair of the epidemiology, that's right, the chair of the epidemiology department, and he's 65, and we're having this discussion. And he's a thin, fit, marathon running peak of health, granola eating. And he said, I've been taking aspirin. I was like, Joe, his name's not Joe. Like, Joe, you don't need to take that. Like, you're fine. You're going to bleed to death. You're going to cut yourself shaving someday and bleed all over. They're like, don't do it. And I said, you're at best. I mean, it's like you're not one of the people that was in this study. I swear to you, you know. So anyway, that's my life. That's just a little peek into my life. Thank you. All right. So, and women, the same goes true, but they don't even start till they're 55. Postmenopausal, they're 55 to 79. They have that window. Now, if you have those risk factors, remember all those risk factors, the diabetes, the hypertension, the history of stroke, the history of MI, okay, then all bets are off, then you're taking your aspirin, or even a whole one, depending on if you've actually had an event, okay? All right, now let's get back to something easy, because I'm getting hot up here. You can screen for blood pressure. Thank you. Whew. All right. You don't screen, down here at the bottom, you don't do EKGs, you know that. And you don't screen for COPD. Now, this one bothers me a little bit. It's tough to figure out that half of people have COPD and don't know it, and yet we're not supposed to screen for COPD, and there's a really easy risk factor, smoking. But unless they're coughing or short of breath, we're not supposed to screen for it. And you can screen for it by having them blow into a little hose for 5 minutes. And they still don't recommend screening for COPD. Now, many of you will have problems with a lot of these guidelines, I'm telling you, but that one seems, I don't know, that one's tough. I think it's because the treatment doesn't alter the course of the disease, and you're treating the symptoms, and so you're waiting for them to be symptomatic so that you're treating the symptoms. But it still seems like it would be motivation to keep them from smoking or help them stop smoking, etc. So, all right, now this is the one I know you don't have another talk till 9, but I'll probably be ridden out of the room now, and so you'll have plenty of time to get more coffee in a minute. I'm going to talk about breast cancer. Remember, I'm just the messenger. I'm not the person. All right. So it's the second leading cause of cancer deaths in women, 232,000 cases, 40,000 deaths. Does anybody know the leading cause of cancer deaths in women? Lungs. Lungs. Okay. It's lungs. All right. Now, the USPSTF in 2009 came out with the recommendation to do mammogram screening in women starting at age 50, in people of average risk, and you could discuss it starting at 40. But they said in average women, you would start at age 50 and do it every other year to up to 75 years of age, 74. We would discuss it. And they didn't say not to do it. And some of the people in the USPSTF explain themselves. They're not telling you not to. What they're saying is that you can, and you and the woman can decide to do it, but that's not for everybody. They don't want to make a mass recommendation. They reviewed the data again. That was in 2009, and it's under review, and they came out with their draft recommendations in April. And their draft recommendations, which have not been fully adopted, say the exact same thing, and they're meeting again in January. So that's what the USPSTF recommendations say. In the meantime, there was one Canadian study. There have been 8 randomized controlled trials of breast cancer screening. This is a tough one. If some of you go to Journal Club or run a Journal Club at your place, this would be a tough one. There's 8 randomized controlled trials, and you have heard on the news this week. They say, well, there's been 8 randomized trials. This is an open and shut case, and I don't know why they're not doing it. Well, one of those said that it wasn't helpful. 2 of them didn't show any difference at all. So out of the 8, there's only 5 that showed that mammography was beneficial. Another thing for you to put in your pipe and smoke it with your marijuana is that one of those 5, and the biggest one, and the one that had the longest follow-up, started in 1963. Now, what did the mammograms look like in 1963? I'm no radiologist, but I mean, if they looked anything like the ultrasounds, I mean, it was like a snowman in a snowstorm. And that's the mammograms that they were using. So the technology has completely changed since then. Doing a study, now, so then you say, well, they just need to do a study and really answer this question. All right. So it's your wife, and you say, we'd like you to be in a study for the next 20 years between age 40 and 60, and we're going to either do mammograms on you or pretend to do mammograms on you, and you're not going to know which group you're in. Do you want to sign up for that? No, the answer is no. And so this is going to be the data we have. I mean, who's going to sign up for the study to not get mammograms for the next 20 years? Randomly. This is a tough one. So the American Cancer Society, as you know, came out this week, and it's been in the news every day, with their guidelines and their reassessment. And they said that women should start at age 45 and get annual mammograms until age 55, and then at 55 do the every other year. Now, so you're all staring at me like, what am I going to tell you to do? Okay, I'm not going to tell you what to do. That's the first thing. I can't tell you what to do. I know this is confusing for women, and I know that it's going to be extremely difficult. The analyses compared women 40 to 49 to women 50 to 69, most of the studies. And so there was a 0.8% incidence of cancer in women 40 to 49 and a 1.8 incidence of cancer in women 50 to 59, and in 60 to 69 it was 2.8. Well, where's the cutoff? I mean, we don't know. I mean, whatever, there's going to be some judgment here, right? So what the American Cancer Society did, which had not been done, they tried to pool all that data together, and then they said, we're going to cut it down to 40 to 44, 45 to 49, 50 to 54, 50, so they cut it down in 5-year increments. So here's the increments for you. Women 40 to 44, the incidence is 0.6. The incidence in 45 to 49 is 0.9%, and the incidence in women 50 to 54 is 1.1. I mean, you don't know what to do, and I don't know what to do with that. So it's not as easy as it seems. These are dedicated clinicians and epidemiologists and experts and guidelines trying to do the best they can with the data that they have. That would be no one is trying to do anything or not do anything or make something be some way. None of the people in the American Cancer Society or the USPSTF said you can't have a mammogram or you shouldn't have it. All of them said, please discuss it if that person has it. And these are people of average risk. You say, well, I have it, my sister had it, my aunt had it, my mother had it, someone had it. Then you're not in the average risk category, and you can get one sooner or more often. What the bugaboo is USPSTF made it Category C. If it's Category A and B, it's covered by Medicare and covered by insurance. If it's Category C, it's not. And so people are worried that if you're 44 or 45, because the USPSTF says age 50, if you're 47 and you want one, and you decide and your doctor says, yeah, go get a mammogram, you're going to pay. So that's my summary of this week's news, and it's not comfortable. It's also interesting that in the public discussion, recently, in the last year, they came out with guidelines to screen for lung cancer. Lung cancer has over 2 or 3 times the incidence of breast cancer. It's the leading cause in men and women. And they recommended CAT scans age 55 to 79 and 30-pack year smokers. And I have not seen one news story, one editorial, one discussion about that whatsoever. And it's interesting. And people just say, oh yeah, I just don't know if I'm going to do that. Which is very interesting to me. But low-dose CT lung scanning is indicated for 30-pack year smokers starting age 55 every year until 79. And that's actually numero uno cancer killer in both men and women. Interesting. And no one said, well, we need to start it at age 53. Or, it was like no one said anything about that. Yeah, interesting. Now this was, okay, if I haven't gotten thrown out of the room yet, and I appreciate you not giving me the hook, they also said that you don't need to teach women breast self-exam. You don't need to examine them, and you don't need to do breast self-exam. So I'm just going to keep moving because that's just, I can't explain it. They can examine themselves, but it's not worthwhile to take the time to teach them. I'm not kidding. All right. Now, we don't want to not forget, and this relates to my talk of yesterday, breast cancer incidence and prevalence would be reduced if women would maintain a healthy weight, do adequate physical activity, not smoke, limit their alcohol, and all these things, and consume 5 or more fruits and vegetables. Every one of those factors has been found to reduce breast cancer incidence. There's a study for every one of those. All right. Now, we have men's breast cancer called prostate cancer. The most common cancer, actually. It's not skin cancer. There's a high incidence of subclinical disease, but there's low mortality. So here's the sensitivity and specificity of digital rectal exam. That's right, 22 to 97%. So this is in different studies, and specificity 22 to 96%. The positive predictive value varies anywhere from 6 to 33%. Transrectal ultrasound was even worse. Although specificity got as high as 97%, the positive predictive value was only 5 to 9%. So these are not good screening tests. So then we come to the granddaddy of them all, PSA, prostate-specific antigen. I'm not sure it should be named prostate-specific antigen because unfortunately it's not that specific. The sensitivity is only 63 to 83%. The specificity is somewhere between 59 and 97%. And the reason there's a range is because it's different for different ages. The positive predictive value, along with a negative digital rectal exam, is only 20%. Then people have said, well, what about the velocity, and what about the ratio, and what about, we just don't have enough evidence there. And 2 recent major trials were inconclusive. They did screening trials. Men were willing to say, I'll get screened or not get screened and get PSAs every year, but not act on the results. And they were inconclusive. I mean, they were just mind-bogglingly full of statistics, but you just couldn't, you didn't know what to do after the study. It was unbelievable. Now, if you find that at stage A, it's 87% survival, stage B, 81%, stage C, 64%, and stage D, 30%. So you want to find it earlier. But most of the time when you find it, it's the simple kind, and you find it when you have 5 years to live anyway. And so the U.S. Preventive Services Task Force recommends against PSA-based screening for prostate cancer. And that's a level D. They say no. They don't say it's insufficient or we don't know or we're not sure. They say no, you're not supposed to do it. Now, they do say that you may have a discussion if there's a family. This is for men of average risk. Remember that. This is, you can always overrule that by patient preference. You can always rule that by the patient-physician situation, by your discussion. And you can overrule that by not being of average risk. And people that are not average risk are people that have a family history of prostate cancer, especially in our age, and African-American men. And so in both of those groups, for example, they have a higher incidence. And so remember, when they do the guidelines, they're giving you general guidelines, okay? All right. Colorectal cancer, colon cancer is the 3rd leading cause of cancer and 2nd leading cause of death. Treatment in the asymptomatic period would provide better outcome, and so it would be good to find it. So it's a good thing to find. And testing is accurate, quote-unquote, simple and acceptable. I think those should have an asterisk next to them. Yeah. How can you do that? You can do fecal occult blood testing. When I talk to men about, because they say, I don't want to have a colonoscopy, I don't want to have that light stuck up. And I say, okay, fine. Or take these cards home and put a popsicle stick in your you-know-what in the toilet and stir it around in there and get some and put it on this stick. And they're like, are you serious, Doc? So that's not exactly acceptable, at least to people in West Virginia. All right. Sigmoidoscopy only gets part of the way up, as you know, and not all the cancers are in the sigmoid, and so that's not going to, there's compelling rationale to look at the whole colon to get a colonoscopy. but it's expensive, it requires more training, it's inconvenient, it's less acceptable to the patient, and now it's become much more expensive, at least where I am, and tell me if this is true where you are, but now an anesthesiologist is involved. So colonoscopy used to be $1,000 or whatever. Now they put you, there's an anesthesiologist there, and it's gone from $1,000 to like $2,500 because they don't want the people in that twilight zone like they used to, but they actually put you all the way out, and the anesthesiologist is there. Is that happening where you are? Yeah, that's happening. Okay. It's actually made it more expensive. Luckily, it's only once every 10 years. But it's increased the usage because you're completely out. Yeah. You don't want that, I'm a little bit awake. I don't know if I was awake or not, but I forgot all about mine, so, you know, hopefully that'll work again. Okay. So you should screen all patients 50 to 75 years old annually with either fecal occult blood testing plus sigmoid or barium or colonoscopy. Most people are going to colonoscopy. What the evidence is good, A, but which method is better is I. They didn't want to make a specific recommendation, but that's under review. It was probably posted on the internet last night at midnight, and I'm already behind. Medicare will pay, so that's good to know. If you have a family history of cancer, if you have familial polyposis, then you start screening at age 35 or 40. All right, so before I leave, the top 10 things to do. The top 10 list. Discuss aspirin use in people at risk. Do pap smears every 3 to 5 years. Lipid panel in men over 35 and women only if they're at risk. Counsel people to stop smoking. Exercise 30 minutes 3 to 5 times a week. Screen people for diabetes if they have hypertension. Not all people, but just people with hypertension so far. Counsel people to lower their cholesterol. More fiber, more fruits, more veggies. I know you probably think I work for the agricultural, I don't. Yeah, I have no disclosures. I wish they'd buy me off. I mean, that'd be awesome. Screen for depression in adults. You say, oh, you're supposed to screen for depression. That's right. If you have a system of care, if you have something, you have to have a plan of what to do once you find them. Mammography every other year, age 50 to 7. I'm afraid to put that on there. Limit alcohol use, and the quiz answer of people that was doing the right thing was actually 7% in this one. All right, now I gave you the top 10 things to do. I thought I'd also give you, as a bonus, the top 10 things not to do. Because there's insufficient evidence, because you might have been thinking about these, and I'll be happy to answer questions about them. Antioxidant vitamins. No. I mean, you can go and eat antioxidant foods, and it's great, but they've been given to people, and they've given people vitamin C, vitamin E, vitamin whatever, it doesn't help. Screening for pancreatic cancer. No, we don't have any way to do it. Screening EKGs. No. Now, if they have hypertension, if they have diabetes, yeah, go ahead and get an EKG. Screening exercise treadmill test. Doc, I'm a marathon runner, and I'm 48, and I just think I need a treadmill test. Like, no. Screening CAT scan for calcium score. There's insufficient evidence. I think the evidence is gaining, and I think that the calcium scores are going to be something that we're going to be doing. PSAs, we don't even need to do a digital. That's right. I have men that are upset, and they come for a physical, and I said, well, Doc, aren't you going to? I was like, no, I don't need to anymore. I was like, what? And so it's kind of upsetting. And so actually, I've done some rectal exams. Well, I know it seems crazy, but I mean, I did it because they just said, Doc, this is what you're supposed to do. Okay. Routine screening for ovarian cancer, because we can't find it. Pap smears in women who've had a hysterectomy. I have arguments with my residents all the time about this, but like, no, it's screening for cancer of the cervix. If the cervix isn't there, then we're not screening for it anymore. Now, if they've had benign disease, if they got it taken out for benign disease, if they got it taken out for cancer, then you got to pap the cuff. TSH screening over age 65, it is indicated because hypothyroid is common, but not under 65. And then, we didn't even talk about this, and it's probably good we didn't because I'm already in trouble with you, is routine estrogen and progesterone post-menopause without symptoms. If you don't have any symptoms, you don't just give people estrogen at menopause. You just do this for symptom control. All right. Think prevention. Thank you, everybody.
Thank you very much. What just brings to mind all the things that we're asked to do on an everyday basis, you know, either as a patient or as a physician.
When you're at the cocktail party, these are the questions that you get.
Yeah, you know, I was looking at your one slide here that I like this statement toward the beginning. Treatment in an asymptomatic period gives a better outcome, and I guess this is what you're looking for, than in a symptomatic period. And I guess that's the basis of what we're doing.
Yeah.
The other day I was walking by our diagnostic center. There's a big sign out front that says, if you have smoked in the last, I think it's 15 years, whether you've quit or not, Medicare will pay for a CT scan of your lungs. And I inquired about that. I grew up in a household with parents that smoked multiple packs of cigarettes a day, so I thought, well, maybe I need to get screened. So I went in and talked to my radiology buddies. I haven't seen any evidence, and of course, they didn't have anything right there, but what have you run across anything about these, I'll say light CT scans that kind of zoom through you and scan your lungs or the rest of your body for things? And, yeah, they said it's a lower radiation, quicker, it's not as high resolution, but if you got something, they'll find it. So
the screening for lung cancer in patients 55 to 75 is something called the low-dose CT protocol. So it is a lighter or low-dose, lower radiation, because you're going to have it every year. And so they have maximized the technology to lower your dose so they're not giving you much radiation by doing it. And so it's a low-dose CT scan screening for lung cancer in people who have 30-pack year history, 55 to 79. Now, what I'm not endorsing, and I haven't seen endorsed yet, is the total body scan for cancer or whatever. No, I haven't.
Of course, that's what I asked. I said,
can
I just get in?
Can you just scan me to see if I got
through
anything?
My pelvis and
like, I'm not sure I want to walk in there and do that Star Trek thing, because they're going to find. I mean, you get CAT scans of the abdomen, and you're looking for something. They say, well, they got a 1 centimeter thing in the end of the pancreas and a 1 centimeter thing in the end pole of the kidney, and there's this little thing of the lymph nodes are a little swollen. You say, oh my God. And then you're going to send the patient a copy of that report, and you say, oh no, this is fine. And they're like, it is? Yeah. And so, I don't think you want to start scanning, total body scanning people.
The scan we need for smoking is to scan your daughter's purse when she's a teenager and your son's t-shirt and kick their butts if you find positive. Okay? The real sad story on lung cancer is that although there is evidence to show there's increased survival at that age range, it's a very small percentage of the people that develop lung cancer. And so it's not a big breakthrough. And what do you do with the person that lives in the Midwest and has histonodules and all the other stuff? Who are we going to sample? And there's consequences to discovering nodules that you take a chunk out of that turn out not to be lung cancer. So I'm still not a great lung cancer screening fan, although the guidelines tell you that. It's much better to have screened early when the kids start smoking and get them off the smokes than it is to worry about them when they're 50, I can tell you.
Apparently this test is something Medicare is paying for.
That's correct. Yeah. That's correct.
Yeah.
I like the way you started your talk. You gave some credence to the legal aspect of the malpractice attorneys. But when you get sued, they're going to be using a new technique. It's called reptile theory against you. I don't know if you've ever heard that.
Reptile theory?
Yeah. Reptile theory.
Okay.
And they're giving seminars all around the country. If you Google it, it'll be reptile Keenan ball. And that's the seminar. And basically, what they do is the plaintiff's attorney will say, well, now, doctor, you'll do everything you possibly do for this patient. Well, that's true. Yeah, I would. But you can't say that, because when you say that, you've already started committing yourself, and they just kind of paint you into a corner, and that's when they strangle you. We been to some
Its name is reptile Keenan ball theory?
Well,
Okay, is that it?
reptile is the theory,
Oh.
okay? Keenan and Ball are two of the seminars you go to.
Oh, I
Go to
see.
seminars around the country. It's a very real theory. It's what they do. You know, what they learn how to do is a technique. You know, it's like when you put in G-tube. You know, we use a certain technique to go from one way or go to the other way. Well, this is the technique they use. It's very, very effective, and it just shows you the deposition process.
Yeah. Why don't we do this? We've got our presentations coming up at 9 o'clock, and we need to kind of get prep for that. If we'll give Dr. King a hand here, and then I'm sure he'll stick around and answer some questions.